Good evening, everyone. So, Dr. Sameer will be presenting on esophageal carcinoma today. Sameer, start off.
Yes, sir. Good evening, everyone. I'll be presenting this subject seminar on esophageal carcinoma. So we'll go through the disease, epidemiology, risk factors, pathophysiology, diagnosis, and finally management and some recent advances. So these are the list of abbreviations which are used in this PPT. So esophageal carcinoma, by definition, it is a malignant tumor arising in the esophagus or esophagogastric junction, staged according to TNM classification. It includes both CVAT type 1 and type 2. So this is the CVAT classification. According to like the previous TNM staging, EGCC 7th, they had included CVAT type 1, 2, 3 all in esophageal carcinoma, but now they have changed it. The CVAT type 3 comes into gastric carcinoma. CVAT type 1 will be from the is G junction till 5 centimeters, and then from G junction to 2 centimeters with the epicenter will be CVAT type 2, and type 3 will be up to 5 centimeters. So as we know, esophageal carcinoma will include both squamous cell carcinoma and adenocarcinoma. While the squamous cell carcinoma is predominant in Asia, but adenocarcinoma is more common in Western country.
No, no, no. I don't think it is more common in Western countries.
I mean, sir, the trend, sir.
Ah.
Yes, sir. So
See, the squamous cell
some
carcinoma is still the
But at 2 minutes.
most common esophageal carcinoma. But the trend is that across the world, especially in Europe, the adenocarcinoma and what is called as a gastroesophageal junction carcinoma, they are increasing significantly, so much so that they are almost equivalent now. The
yes,
adenocarcinoma and squamous cell carcinoma are equivalent, but in Asia and other areas, it is still squamous cell still high. But the trend is, as you said, it is increasing.
so esophageal
This is
carcinoma
very
is the seventh
important
most.
because of the treatment modalities, which is why you need to know this.
Yes, sir.
Okay.
So it is the seventh most common cancer worldwide, with sixth most common like leading cancer death. About almost 5,400 like 500 and
5 lakh.
44,000 people
Yeah, 5 lakh.
die from the esophageal cancer worldwide. As of for Indian population, it is the sixth most common cancer and sixth most common like leading death in our India. And almost 57,000 people die per year to and succumb to esophageal carcinoma. The China, like it alone has a 50% burden, and then Iran, males have a higher incidence with also leading deaths than females. As we have said, discussed earlier, esophageal adenocarcinoma is increasing in trend, but squamous cell carcinoma is still dominates. As of for risk factors, so in high incidence regions such as China and Iran, there are particular risk factors such as heart beverage, caustic injury, tobacco, alcohol, the consumption of nitrous amines, and polyaromatic hydrocarbons because of the use of indoor fuel, poor oral hygiene, and low socioeconomic status. Whereas the esophageal adenocarcinoma has a like predominantly in Western countries because of GERD, Barrett's esophagus, increasing obesity, male sex, and smoking. So there is this controversial or a paradox is seen in cases of Helicobacter pylori. Helicobacter pylori is actually protective in cases of adenocarcinoma because it causes decrease in the acid secretion, But the same for squamous cell carcinoma can't be said. There are several studies, and we are yet to determine that if it is pathogenic or protective for squamous cell carcinoma. Coming to the genetics, esophageal squamous cell carcinoma, they will arise from the native squamous epithelium in upper and middle thoracic esophagus, and it is strongly associated with alcohol, tobacco, and environmental carcinogens. These carcinogens will result in a field cancerization effect, both in esophageal squamous cell carcinoma and the adenocarcinoma. T53 mutation is common. The sorry. The molecular landscape will differ substantially from this adenocarcinoma. Squamous cell carcinoma exhibits a alteration in genes. As you can see over here, there will be alteration in Notch1, SOX2 amplification, and also there will be over expression of cyclin D1. The same for in contrast to adenocarcinoma, it typically arises from distal Barrett's esophagus through a metaplasia dysplasia carcinoma sequence driven by a chronic gastroesophageal reflux disease. The most frequent genetic alteration in esophageal adenocarcinoma is again T53, TP53, and it shows an amplification of tyrosine kinase, HER2, and EGFR. It makes the esophageal adenocarcinoma more amenable to targeted therapies. So these are some anatomical features which we had already discussed in the
Sameer,
anatomical.
sorry to
Yes,
disturb. You have forgotten achalasia as one of the other risk factors for malignancy for both squamous and adenocarcinoma. Achalasia.
Yeah.
okay. Yeah.
Yeah. And some genetic syndromes are also there. Hyperkeratosis, that tylosis.
Hello?
Hello?
Samir, you're
Yes,
there?
sir.
What
Yes, sir.
happened?
Yes, sir.
What happened? Hmm.
Some.
Okay.
Samir,
Yes, sir.
continue then.
Yeah, yes, sir. So these anatomical features, like specific to esophagus, such as it has a squamous epithelial lining up to upper two-third, makes it sensitive to chronic irritation from tobacco, alcohol, and hot beverages. There is absence of serosa, which causes early local invasion into adjacent structures, and it has a rich submucosal lymphatic plexus, causing early skip metastasis. Although it is a long tubular organ, but like because of it, it has an high exposure rate to carcinogens. There will be early dysphagia in patients, but the patients get used to it and they take like diet accordingly, and then they will present late. There will be a late presentation. Esophagus has both thoracic location, which makes it again difficulty for early detection, and as I've already said, there are multiple lymphatic pathways causing earlier skipments, and treatment to esophageal carcinoma more complex. So, as we have discussed earlier, esophageal squamous cell carcinoma will typically derive from a esophageal epithelial cells, wherein there will be first low-grade intraepithelial neoplasia because of risk factors such as drinking, smoking, hot beverages, and then it will progress into high-grade intraepithelial neoplasia, and finally, there will be the breach of basement membrane when into the lamina propria, which will then grow into invasive tumor. On the other hand, as we know, esophageal adenocarcinoma will arise from a columnar lined esophagus, which is typically due to exposed gastric reflux and Barrett's esophagus. But even there are non-dysplastic Barrett's esophagus, they can also grow into esophageal adenocarcinoma. Studies have shown that. As of for symptoms, uh, esophageal carcinoma mostly will present with progressive dysphagia. Initially, patients will have dysphagia to solids, later to liquids, because of like the gradual circumferential tumor growth, which narrows the lumen. So until there is a 60, more than 60% obstruction, patients like it won't cause significant obstruction, which explains the late presentation of patients into in for treatment. And these patients, because of progressive dysphagia, they will have marked weight loss, resulting either, both from the reduced oral intake and also cancer related cachexia and increased metabolic demand. Further, patients will have odinophagia, which will occur when the tumor will ulcerate the mucosa and expose the sensory nerve endings, causing even retrosternal pain if there is infiltration in the infiltration or mediastinal involvement. Regurgitation may develop because of food stasis and like above the obstructed part. And advanced diseases can have hoarseness of voice, cough, and aspiration, which suggest tracheoesophageal fistula formation. Can I go ahead, sir?
Yeah, yeah.
So, screening for esophageal carcinoma is not recommended for the general population, but it is targeted towards high risk individuals, particularly those at risk for adenocarcinoma arising from Barrett's esophagus. Current practices focus on patients with chronic GERD, especially with males over 50 years and with additional risk factors such as obesity or smoking, in which upper GI endoscopy has already detected Barrett's esophagus and dysplasia. If Barrett's is identified, then periodic endoscopic surveillance is advised and based on the grade of dysplasia. So these are the American ACG guidelines, ESG guidelines, and British Society guidelines. And the surveillance method is either by white light endoscopy or adjunctive chromoendoscopy and structured biopsy. There is also non-endoscopic screening, which is a tool. It is a minimally invasive screening tool developed to detect Barrett's esophagus in high-risk patients who have chronic reflux symptoms. So what happens is patients will swallow the gelatin capsule, which you can see in 2A image, and then once the capsule goes to stomach, it will dissolve and it will expand into a small sponge kind of a thing, and then this will be connected to a thread, and then we will gently withdraw the sponge and collect the esophageal epithelial cells along the path. These esophageal cells are then analyzed for TFF3, which is trefoil factor 3, which is a marker of intestinal metaplasia. As we can see in the image 2C, there is a goblet cell, this one, like intestinal metaplasia we can see. So the major evidence of supporting this approach comes from the best 3 trial. This is the best 3 trial, which like it was a randomized control trial wherein 13,000 patients were
ಕ್ಲಾಸ್
evaluated with
ಕ್ಲಾಸಲ್ಲಿದ್ದೀನಿ ಕ್ಲಾಸಲ್ಲಿದ್ದೀನಿ ಹಾಂ ಬೆಳಗ್ಗೆ ಮಾಡಿ
randomized control trial wherein 13,000 patients were evaluated with cytosponge TFF3, which is the pill-on-a string for detecting Barrett's esophagus in primary care. This has identified biomarkers and significantly increased diagnosis rates up to tenfold, and they like early stage cancers are found, and we can go ahead with you like treatment. So, diagnosis of the disease, once we suspect esophageal carcinoma, we have to detect, go for primary, like the primary lesion, staging of the disease, and some special studies. As we know, endoscopy is indispensable for esophageal carcinoma. Here we see a image of white light endoscopy, wherein the A is showing normal endoscopy, B is showing some low grade dysplasia, some patches of low grade dysplasia, C is showing high grade dysplasia, and D it is the squamous cell carcinoma. The similar one which we can see in lugal side in stained images. So lugal side in because the cancer cells have a depleted glycogen like they are depleted of glycogen, so they are not stained by leukocidin, and these patches can be seen as pinkish patches against the dark background. So this is one more image. These fields, as we can see, the pink one, which are like the red arrow, which are showing islands of pink over there. These are observed after 2 to 3 minutes of leukocidin staining, and these are the suspicious like images. Then we also have the narrowband imaging. In patients with a background of Barrett's esophagus, we can go for narrowband imaging. So narrowband imaging works by because there will be green and narrow blue wavelengths which are absorbed by hemoglobin, and they will have superficial microvascular patterns. As we can see, the red arrow is the suspicious lesion, and with narrowband imaging, we can again incorporate magnifying endoscopy, and then we can see the different like grades of intraepithelial neoplasia. These neoplasia gradings are done by the Japanese Esophageal Society, wherein we can see normal intrapapillary capillary lesions, and up to type B3, which is type B3 will detect that the submucosa is already infiltrated. So, narrowband imaging with the magnifying endoscopy can aid in like better visualization and also like earlier detection of these suspicious lesions. So, according to the current guidelines, initial staging is to be completed through computed tomography with a intravenous contrast of chest and abdomen. CT scan alone has shown a sensitivity of around 66% and a specificity of 61%. Over here, we can see a esophageal carcinoma with lymph nodes, regional lymph nodes. Finally, for the T staging, the best modality will be endoscopic ultrasound. It can examine the tumor depth, evaluate the regional lymph nodes, and then it assists in staging process and treatment, like treatment plan. The accuracy of endoscopic ultrasound varies from 74% to 93% depending on the tumor stage, and it is best for T stage accuracy and regional lymph nodes, and obviously it cannot detect distant metastasis. In the first image, we can see a hypoechoic mass arising from the mucosa going until the submucosa with some extension to muscularis propria. And in the second image, we can see hypoechoic, sharply like demarcated borders with rounded contours, which are the lymph nodes. For metastatic workup, PET-CT is done to see like other mets to like book. Yes, sir.
Class ಅಲ್ಲಿದ್ದೀನಪ್ಪ.
Finally, in upper and mid thoracic.
Wait, Samir,
Sir,
wait.
sir.
Tell us what all you will do. You explained all the tests, no? If a patient comes to you with suspected esophageal CA, what is the like sequence of investigation? What you will do, or you will do all those which you told?
No, sir. Primary lesion we have to find by endoscopy.
So, what is the
Prefer
first investigation? If patient comes with suspected
endoscopy.
esophageal CA, okay, then
Yes, sir. then
You
we'll
say you take a then what you will do after endoscopy?
sir, endoscopy, then uh, because we'll be seeing the lesion, we'll get a biopsy,
Okay.
and
Then
to stage the disease, sir, we have to get a CT done,
what CT?
like contrast CT, sir.
Of what?
Like contrast CT of chest and abdomen.
Okay.
Yes, sir. Then
Or
If it's
or
upper
PET CT, sir.
esophagus, you will not do neck CT scanner.
Sorry, sir.
If it is of the
neck.
upper esophagus, you will also include the neck, no? Not only chest and abdomen.
Yeah, yes, sir. Yes, sir. Or we can go ahead with PET CT, sir. If
Okay. The advantage of PET is you will know the metastasis as well as you will don't have to like the cost probably will be lesser when compared to you do a CT neck, CT chest, and CTC, CT abdomen pelvis. But although the textbooks say it is the CT picture to do first. Okay. Then
But
when do
the
you, when
sir, but
infiltration and
for
other things, better to have a CT. At least, if for example, if you have a thoracic one, do the thoracic CT and lower esophageal, yeah, abdominal thoracic CT, because the PET CT will not give you the characteristics which you need for planning the surgery. It will only tell you whether there is infiltration and the local lesion and all that, but its surrounding so the relation to surrounding structures, all these things will not be described by the PET CT thing.
when will you do endo ultrasound?
sir, once we have seen the lesion, to to properly detect the T stage, we have to do an endoscopic ultrasound.
Is it always mandatory? If you have done CT,
Yes, sir.
so then you also do will you also do endo ultrasound? When will you do endo ultrasound?
So if CT has
Sir, you can't keep it.
yes, if CT has ruled out like there is no distant mets, then we have to go for US, sir, to detect like the
Why?
regional. So depth of invasion we have to know, no, sir.
No, how will it change? What will it change?
Sir, if it is early stage, we can go ahead with just endoscopic mucosal resection or endoscopic submucosal
That you tell. That you
Hmm.
tell.
Okay, sir.
Uh,
Yes, sir. And even
hmm.
regional lymph nodes are best detected by US. And it can also, we can have a FNAB of those regional lymph nodes.
Correct. FNAC or FNAB.
Yes,
Yeah.
sir.
Sir, any other comments, sir?
No, I think whenever you are expecting to do a local EMR or then I think for early esophageal cancers, maybe endosono will be good adjunct. Um, but otherwise, the CT and PET CT were probably endoscopy are the three investigations which will help us to state the disease and also give us the anatomy and its relation so that you can plan the surgery or whatever else you need to do.
Niharika, ma'am? Any
Yeah, I
comments?
think I agree. Early lesions you will do in US, so that you can decide whether you want to do an EMR or ESD. And yeah, that's about it.
Okay.
If
Swaroop?
someone is suspected to have tracheoesophageal fistula, what investigation you prefer?
Sir,
What
bronchoscopy,
contrast
If
will
somebody
we?
has
Hmm.
sir,
tracheoesophageal fistula, what investigations you will do?
bronchoscopy, sir.
That's okay. Anything better than that? Anything easier than that? It's okay. Proceed, we'll speak.
Barium. Barium you can do. You avoid these osmolar dyes, contrast agents, because they
I
can
think,
precipitate pneumonia
yeah,
and all of that.
gastrographin, oral gastrographin you might give to see if
Yeah,
there is any leak.
yeah.
Barium, I think you need to avoid
No,
because it might cause chemical, can be given, huh?
barium can be given, but these hyperosmolar contrast agents should not be used. It can cause pneumonitis and yeah, chemical
Okay.
pneumonitis. Yeah.
Endo ultrasound will also probably tell us.
The
And
amount
also
of
I
leak can
probably
be seen
HRCT.
by contrast only. The amount of leak which
HRCT.
happens,
Huh.
that also. Yeah.
Hmm. Okay, Samir, go on.
Yes, sir. So in patients whom we are expecting, we are like if at all we are seeing a airway involvement, then we can go for bronchoscopy. Bronchoscopy will it will tell the T4A versus T4B disease. Like as we can see over here in the image B, it depicts the T4A disease where there is only there is no involvement ulceration or direct involved tracheobronchial mucosal invasion. So these patients are still they will come under resectable category. While in the image which shows the A1, we can see the ulcerated with luminal narrowing and direct tracheobronchial mucosal invasion. These patients will go for T4B, which is considered unresectable and managed with chemoradiotherapy.
But before giving chemoradiotherapy, anything to be done for that to
Sir,
cover? Do you need to do anything before giving chemoradiotherapy if there is a fistula?
sir, clips are your meaning or?
No, covered stent, man. Covered
Oh,
stent.
Covered
covered.
stent.
Giving
Yes.
chemoradiation will worsen the fistula by making the fistula larger.
The all the other students, they are all keeping quiet. Only the teachers are talking. Please, all of you have to participate in this. I hope you have all read and come to the class. And you have to ask questions. You have to make comments. Add whatever you know. You're all sitting there, just not talking. Okay, carry on, Samir.
Yes. So the HSCC 8th edition for staging, it stays the T stage into T1S till T4B. T1S will be high grade dysplasia. T1A will be invading the lamina propria or muscularis mucosa, and T1B will be invading the submucosa. Then muscularis propria will be T2. When once the adventitia is invaded, it is T3. Then we can go T4A and T4B, which I just discussed now. T4A will be the invasion of pleura, pericardium, or diaphragm, and T4B will be invasion of major structures such as aorta, vertebral body, trachea, or bronchi, which are deemed unresectable. Then for the N, there will be from N1 to N3, from 1 to 2 positive nodes till more than 7 positive nodes, and metastasis M0 or M1. Also, the staging has been changed for esophageal adenocarcinoma and esophageal squamous cell carcinoma. They have added the grades for staging. Grades 1 to 3, uh, 3 being poorly differentiated. These squamous cell carcinoma tend to grow faster. They invade the deeper structures earlier. They will spread to the lymph node sooner and have a high recurrence rate, and according to studies have a low overall survival. So they have added the grades until stage 2A, and after 2B, the nodal status becomes the major thing for staging. There is also YPTNM staging, wherein patients who have received the neoadjuvant chemotherapy, they are staged according after the NACT.
This pathological stage. After NACT you remove, then you stage.
NACT plus surgery, sir, after. Yeah, that one, sir.
Correct.
Yes, sir. So I'll proceed, sir, for management.
Yeah, yeah.
Yes.
Yes,
For sir, for early esophageal carcinoma, uh, in cases of like high-grade dysplasia, whether it is squamous cell carcinoma or adenocarcinoma, endoscopic eradication therapy can be done. For T1A, squamous cell carcinoma, we can go ahead with EMR or ESD, which I'll be discussing in the later slides. And alternative will be again esophagectomy. After T1B, submucosal superficial lesions and submucosal lesions, we have to go for esophagectomy with lymphadenectomy or chemoradiation for non-surgical candidate. As of for the endoscopic treatments, uh, this is endoscopic mucosal resection. The image over here is actually showing the banding cap technique, wherein once the lesion is marked, like a band ligation device is done over the lesion, and it will make the lesion to form like a pseudo polyp kind of a thing. And this band will then allow the insertion of electrocautery snare to resect the lesion above or below the band. So this technique has shown up to 92.3% clearance, and in cases of squamous intraepithelial neoplasia, the complications being acute bleeding and esophageal stricture. As of for submucosal dissection, once the margins of the lesions are visualized, either we use a argon plasma coagulation or the submucosal dissection knife. So here, once the markings are made, we do a submucosal injection repeatedly, so that we be on the like in the submucosal plane only. After achieving the dissection, the exposed vessels, they can have a risk for bleeding. Patients who have underwent ESD, the potential advantage will be tumors can be removed en bloc regardless of the size, and this may improve the pathological like precision of pathological staging and lower recurrence rate. Adjunct to EMR or EST will be the RFA. So radiofrequency ablation, which is the most widely used technique. It uses radiofrequency thermal energy bipolar electrodes to deliver heat to, and it will lead to coagulation of proteins and cell necrosis. Because there is a limited depth of ablation, so RFA should be performed only after the nodular and raised lesions are resected. There are also studies who show that RFA can be done for low-grade dysplasia also. And we also have the argon coagulation, hybrid APC. Here we lift like it will have a lifting agent. And once we see these cushions of Barrett's esophagus, um, argon gas is used. So what it does is it once the argon jet is in contact to the tissue, it will selectively destroy those lesions. So, but there are no prospective studies which have been done, like no randomized control trial to compare the outcomes of this hybrid organ coagulation or radiofrequency ablation. I think so. I'll go ahead.
Yeah, go on. We'll ask for opinion later. Yeah.
Yes, sir. Sir, after the surgery only will come, sir. So that's why.
I think you didn't describe the APC correctly, Samir. Argon plasma coagulation uses
Sir,
the diathermy along with the argon gas. So the advantage is the spray is very superficial. So it will only burn the very superficial areas of the mucosa. It doesn't penetrate. That is the advantage of APC. So usually used for Barrett's esophagus, but I think Madam can correct me if now they are using for malignancies also.
I think so. You're right. It's only for parrots, not for early malignancy. I think we prefer now EMR and ESD.
EMR, ESD,
Yes, sir.
yeah.
Yes, sir. Yes, sir. Because we get tissue also, whereas in
Correct.
RFA and APC, organ plasma coagulation, we don't get tissue, and we don't know whether we have completely eradicated the lesion.
So, Samir,
sir,
what are the what are the pitfalls of you doing EMR and ESD?
it falls. Yeah.
In other words, what is the lymph node metastatic rate in early esophageal cancers?
Mm,
If it is mucosal, then it is less than 10%.
7
If
to
it
10,
is,
sir.
Yeah,
yeah.
yeah. So the what you have to answer to this question is patients consider you are considering them for because esophageal cancers have very poor prognosis and as such think it is improving with the newer modalities but still it has very poor prognosis. So you have one proper chance to deal with it. So you have to state the disease properly. You have to do whenever you are considering doing local treatment, you have to do a endosono. You also have to have a PET CT to ensure that there is lymph node metastasis is, where the lymph node metastasis is because of what you said yourself. The lymphatic plexus and the lymphatic, this one is so rich that about 30% of cases of upper and middle third of esophageal malignancies, there will be metastasis into the abdominal group of lymph nodes and vice versa. The lower third, in 30% of cases, we will have mediastinal and cervical lymphadenopathy. So this is why by doing just local therapy, it won't help you unless you are absolutely certain that there is no lymph node metastasis and it is only the disease in the local disease that you are dealing with. Swaroop?
It's correct, sir. But a lot of pathological things should have been discussed also regarding adenocarcinoma, squamous cell carcinoma. I should have told the sequence from metaplasia to carcinoma,
He said
which
all
side
that.
of esophagus, which site is more prone for adeno, which site is more prone for squamous, and management of cervical esophagus as a separate entity because they behave like hypopharyngeal cancer more than esophageal cancers. And for the pathology aspects, we'll have to look at PDL1, MSI, and HER2 status because the guidelines which she has prescribed has evolved a lot and it is continuing to evolve. And currently, we can even say that squamous cell carcinomas perform better because of their higher response rates to immunotherapy compared to adenocarcinoma. Whereas adenocarcinomas are more gastric cancer kind of behavior.
Yeah. What about radiotherapy for squamous cell carcinoma? You don't do it any longer. You straight away go for immunotherapy.
No, no, sir. Radiation therapy is also part of, it's actually one of the backbone of management if surgery is not feasible in somebody. For example, in cervical esophagus, we cannot resect it very close to the hypopharynx. So definitive chemoradiation is there. But many patients who in real life are not very fit for radiation therapy upfront. They'll be malnourished and all those things. So we start them off with neoadjuvant low dose but weekly chemotherapy. And once nutrition is achieved, what happens by the time the esophageal lumen opens, we actively pursue on nutritional improvement. They gain 2, 3 kilos of weight. That's when we start radiation therapy. The other thing here is that we should be very careful to not elicit a very fast response in esophageal cancers because there's a very high risk of fistula and perforation if we start chemo and radiation together in somebody who has a through and through lesion. So many practical variables are there in management. Recently, the standard has become to start one cycle of immunotherapy followed by standard chemoradiation therapy has doubled survival. It's a recent publication I'm
So
sharing.
What is the immunotherapy which is given?
Those people have used nivolumab single dose.
not
That is
pembrolizumab.
They're basically
IV.
the same, sir. They're all the
Huh?
same actually. They do the
Ah,
same thing. One, the manufacturers are different. They're all PD-1 inhibitors.
okay, yeah.
So that is IV
Yes, infusion.
Even
infusion.
if
Okay.
even if they are HER2 negative, you use pembrolizumab or
HER2 negative only we'll prefer.
hmm,
If HER2 positive, then trastuzumab comes into picture.
okay.
Squamous cell carcinomas are usually HER2 negative only. Adenocarcinomas, there is 18 to 20% chance of HER2 positivity.
Carry on, Sameer.
Yes. So this is a flow chart which shows how to like we manage locally advanced carcinomas. So EMR, EST, and ablation we have already discussed. In for patients who are stage T1B to T2 N0M0, the surgery will be the mainstay. And
Of
according
what?
to
Of what type you have to mention specifically? You cannot generalize for squamous and adeno.
sir, we are
Hello?
like for distal upper and upper mid and subvocal, we are those
Huh?
approaches you are telling, sir.
Yes, man. So you cannot generalize and tell that T1, T2 we will go for surgery. For you have to specify. Hello?
Yes, sir, approaches are there, sir. I'll tell everything. Like,
No, no, I'm not talking about
uh,
approaches via surgery. I'm talking
sir,
about approach to management. It depends on the type, type of cancer, depends on the site of cancer also. The management, you cannot generalize, that is what I'm telling.
okay, sir.
No, tell us.
Yes, sir.
Why are you keeping quiet?
For T2N and T3N lesions, according to guidelines, we are following the pre-op float protocol or carboplatin with
No,
paclitaxel.
Samir, this
Sir,
is where, what type of cancer? Again, you're going for T1, T2, T3, T4. It is not like that. That is what Swarup also said. Did you understand what Swarup said?
sir, but for T1B and T2N010 lesions, we like surgical approach will be same, no, sir. For
No, man. Did you understand what Swarup said?
sir, sir, that is
Adenocarcinoma treatment is different. Squamous cell carcinoma treatment is different. Swarup?
yes, sir, but that will come after T2N like N node positive lesion, sir.
No, 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 no. You're getting confused. Swarup?
Samir, start from the beginning about this slide and carefully reword your words.
No, no. He's asking T1, T2, T3, T4, it remains the same, he's telling. It is
He's
not
No,
right,
sir,
no.
No, he's telling
T1B
for
and
T1 and
T2.
T2 separately.
No, no, management. It is based on the type of cancer also, no?
Yes, it is the type of cancer, location of cancer,
Hmm.
both will matter. and also the person's overall fitness, operable, inoperable, those things also will matter.
Samir, you're talking about locally advanced carcinoma of what type and what site?
Samir,
Sir,
you have written it there. Surgery for uh,
yes,
uh,
sir. But then, sir, until
esophageal adenocarcinomas and for squamous cell carcinoma, you can either consider giving neoadjuvant chemoradiation and then looking at the pathological response, you can see whether they need to be operated or you need to observe them. Because
sir,
many of the
but
squamous cell carcinomas are very responsive to chemoradiation. And now
You
what
don't
he
do
says,
generally don't do surgery for them.
and immunotherapy now. Immunotherapy is also going to be very useful. But major, see the you have to generally say it. Of course, it is all. Main thing you should have said is it is all discussed in the multidisciplinary team meeting, and based on you have to what you call as the prioritize the treatment according to what is individual therapy for considering the patient's disease and patient's general condition. But general rule of the thumb is for adenocarcinoma, surgery is the treatment, and for squamous cell carcinomas, chemoradiation is a treatment plus or minus immunotherapy.
To make it simple, you should remember that squamous cell carcinomas behave like head and neck cancers, the typical nasopharynx, hypopharynx kind of behavior, whereas adenocarcinoma behave like gastric cancers. So in gastric
Yes.
cancer, the upfront, I mean, the main backbone of treatment is surgery. Though we may use perioperative chemotherapy and all those things, the mainstay is surgery. And in head and neck cancer, the mainstay is chemoradiation therapy. So it's that's how it is different. And I've also shared a national comprehensive cancer network guidelines about esophageal cancers. Take some time to go through that. You will see how different the guidelines are for squamous and adenocarcinoma.
This is the
Hope you
ICMR
understood,
guidelines.
Samir.
okay, okay, sir.
Saru, the
I
latest
didn't get this.
ICMR guidelines or
No, this is US guidelines,
European
NCCN,
NCC.
American.
Okay.
So, I had one doubt, sir.
Yes, Anas.
Like, what management like that chemo radio standard for squamous cell and mainstay surgery for adenocarcinoma is for locally advanced like T3 T4 lesions. Like, if it is T2 esophageal cancer, like T2N0, then in those cases, shouldn't squamous cell carcinoma go for upfront surgery and like adenocarcinoma get preoperative or neoadjuvant chemotherapy, sir? Like chemo.
No, no, I didn't understand your question at all.
So, like now, as sir said that the mainstay treatment for squamous cell carcinoma, we consider chemotherapy and
Correct,
immunotherapy, and for
correct,
adeno-CA, surgical management. So,
correct.
is this applicable for locally advanced carcinoma or for all?
No, no, locally, no, no. It is T1, T2 if it is adenocarcinoma, upfront surgery, and followed by adjuvant therapy of chemotherapy. So if it is squamous cell, generally the preferred mode of modality of treatment is upfront chemotherapy, either in combination with immunotherapy and radiotherapy, or surgery is considered only if it is not responsive. Correct, Swarup?
Correct.
In locally advanced adeno-CA, you give neoadjuvant CT. I don't think RT helps there, adeno-CA,
No,
and then
not
you
much.
go for surgery.
There are some protocols where they use RT also, but in those same trials, when they stratify adeno versus squamous, they've seen that adenos respond poorly to radiation.
So if it is locally advanced adeno-CA, you go for upfront neoadjuvant
Neoadjuvant chemo, then
chemotherapy followed by surgery, depending on the response, and then again CT if required.
Okay, okay, sir.
What is
let me proceed.
flot? What is flot, Samir? Samir, FLOT. Are you there or
Hello,
not?
hello. Yes, sir.
What
Yes,
is
sir.
FLOT? Flot.
Sir, flow, that was the protocols are in
Don't
gastroesophageal junction
don't
cancers.
give me protocol, man. It is
Yes,
5-fluorouracil, leucovorin, oxaliplatin, and what is T?
taxotere, sir, taxotere.
Docetaxel, correct.
Docetaxel.
Mm.
You should know, see, copy paste doesn't work. You should know what you're talking about. So is it clear? So I think let us leave it to Swaroop to clarify the treatment, this one, algorithm. Swaroop,
So first of all, if it's an exam, the student should first of all acknowledge that it's an evolving process and that guidelines keep changing every day and they're so much changing that even it's difficult for us to keep pace with. But in a person with esophageal cancer in real life, we may find somebody who is fit for treatment as per guidelines. Some people are not fit for guidelines. For example, somebody may be so frail, even surgery and chemotherapy not be feasible. So somebody may be fit for surgery, but preoperative evaluation may find that they are not the right surgical candidate. So for operable esophageal cancers, there are different types of surgeries. I think that will be covered in a different class, I believe, sir.
No, I think he will
The
cover
types,
next after this if there is time.
okay, the types of
Yeah.
esophagectomies and all those various
All
of
those things he will cover. Yeah. Overall,
that will
just
not be covered.
summarize the approaches first.
When we look at the complexity of surgery, sometimes we feel chemoradiation is easier. Go and resecting all those lymph nodes, and sometimes during surgery, most times they find some surprise finding which was not previously seen. They may see some lymph node somewhere. So it's not very easy, and post-operative complications are also there. In somebody who's already frail, and ending up with a mediastinal leak may not be very easy to deal with. So convenience part, neoadjuvant chemoradiation therapy. There is a protocol called as cross protocol, where they use a intermediate dose of radiation therapy instead of very high dose or low dose, 41 gray of radiation therapy with weekly low dose paclitaxel carboplatin. This was evolved in the UK, and this protocol has seen very good responses, especially in squamous cell carcinomas, and pathological complete response rate has been 40 to 50%. But for adenocarcinoma, the neoadjuvant therapy will be the FLOT regimen, which was just now spoken to by Ravi Shankar sir. So this is the current standard, but the guidelines are going to change very soon because there is data from the East and the West in which PD-1 and PD-L1 inhibitors are shown to improve outcomes significantly. Wherein we integrate immunotherapy, the right sequence is still not known, whether to do immunotherapy first and then chemoradiation or to do chemoradiation along with immunotherapy. There are various studies going on, but the response rates are nearly doubling, we can say. Like if the pathological complete response rate was 30 to 40%, we are now seeing 60, 70% pathological complete response rate. But final data is still awaited. Regarding radiation therapy, we should be careful about the amount of radiation which is going to the nearby critical structures, mainly the spinal cord and the lungs. And many people who are elderly with COPD, who have chronic smoking history, they have very bad lungs. COPD will be there. That will also make radiation therapy delivery difficult in these patients because we'll be restricted to the amount of radiation we can give to these people. So in real life, many times we are just doing neoadjuvant chemotherapy followed by sequential radiation therapy or surgery. So, but you have to go through guidelines. That is the reason I have shared you the NCCN guidelines. Uh, Skip the first few pages and go to the, I'll just tell you the page numbers I've opened in my computer. Uh, Start from page number 11 of the PDF. If you go to 11 PDF, you'll see squamous cell carcinoma stage 1 to stage 4A, multidisciplinary evaluation. Then medically fit for surgery versus non-surgical candidate. For both of them, there is a different pathway. Very frequently seen, somebody is due for surgery, but they're not medically fit. So that part you should see. And then after surgery, what is to be done? It's very clearly elucidated. You can go through this, and if you have any doubt, you can ask me tomorrow whenever you want. And there are separate guidelines for squamous cell carcinoma. You can see in page number 13. And then when you go for adenocarcinoma, you can see it from page number, I will say, page number 22 onwards. It, it looks a bit complex, but if you see one or two times, you'll remember. It's not very difficult. Very superficial lessons. Try to see if you can do endoscopic resections and all those things. Sometimes in very frail elderly patients, you may just do some stenting and leave them. Actually, that will be better than to aggressively treat them. So please do look into the PDF which I've shared, and
Yes.
I think we can proceed.
Yeah, carry on, Sameer.
Samir, how many more slides?
Sir, 20, 24. Sir.
Sir, it's already 10. Should we
Hmm.
discuss surgery separately?
Yeah, I think we should discuss surgery separately. I
Because it
think,
takes a lot of time to
yeah,
discuss.
surgery, the this one robotic resections now, which have become standard. All of this, I think we should probably, yes,
And complications also.
surgery for CA esophagus, it should be a separate class. But more and more with the, I think, because surgery is such a, the morbidity and mortality associated with esophageal resection still is very high. Not just because the surgeons are poor or anything, it's just that the disease is like that. Second is you have very bad specimens. Patients are either, alcoholic and smokers, and so their, lung reserve is very poor, and so all of these things will add to the problem. Even though surgery has gone very well, they will succumb to pneumonia and things like that. So, and because they have already very bad background, COPD and things like that. So that is why surgery, should be, the selection for a patient for surgery is now becoming more and more critical, which is why level 1 evidence suggests that the multidisciplinarity meeting is extremely essential to determine the customization of the treatment for individual patients. Questions? I think Niranjan, questions
Yes,
from the
sir.
student.
Students, let them ask. They have been quite, very quiet. Except Aina's, no one has opened up.
Sir, one
Likit,
lesson.
yeah, tell.
Sir, for early lesions, like until T1B, like, and if we are excluding the cervical, like non-cervical esophageal cancers, we can still go ahead with surgery. No, sir. Like we have to do a R0.
Yeah.
No,
See,
sir.
this is what we have to discuss. This is what I told you, that all treatments have to be customized. See, patient may have an early lesion in the thoracic, the squamous cell carcinoma, but maybe a very poor risk as far as surgery is concerned. So in such patients, you will not operate on them. So that is
Yes,
why
yes, sir.
it is
Yes.
not one size fits all kind of treatment. It has to be customized. So you have to decide based on the disease factor and the patient factor. Both of them are critical. Some patient may be very fit but have very bad disease, and vice versa. So you have to, decide how you do. But what we said was the, sort of the
General guideline.
rule of the thumb, which says squamous cell carcinoma more, because it is more responsive to chemoradiation, and adenocarcinoma is less so, which is why surgery becomes more important. That is all.
And so also
Anyone
like
else?
in T1, even if it is T1, if mucosal resection is possible, but if it is a poorly differentiated carcinoma, then we won't opt for
Yeah,
EMR.
yeah,
So, no.
You don't.
Okay.
That is what he had very clearly made. So when there is, that is why endosono becomes very important. So it
Okay.
will,
Yes.
and then the biopsy. Endosono will also maybe give you information about the, in pathology they will tell you when the biopsy is taken whether there is, so neurovascular, the lymphovascular invasion and all of these things. And if that is there, then you don't consider doing the, EMR.
I just shared one slide on the group you can see in us.
Karthik, you have been very silent. And these two new young girls, you're not talking. You have understood everything? Malavika, have you understood everything that we have said today?
Not completely, sir.
Huh? But then you
Not
have to
com-
ask, no? Ask questions where you
Then
have
if you
not
have
understood.
any doubts, don't be hesitant. You can speak up.
Sir, I'm trying to understand what is.
You have to read up and come. I clearly shows that you haven't read. Did you read and
And
come or
what,
not?
Uh, read only little, sir. Not the main surgical things and all. I have not read, sir.
See, actually, if you know, these days, literature is so easily available. If you go on to PubMed Central, you get full articles. Actually, there are so many articles, so many new articles which which is giving you the guidelines and everything. What Swarupas, quoting and all that. It is all easily available. So you have to, and those are very well written. They are very. The language is very simple, very clear, succinct. You can understand it. Go through original articles. Don't just textbooks have to be read, but you, as postgraduates, you have to start looking into journals.
Yes, sir.
and also whatever part you're not understood, no, you should ask up now. Ask whenever we ask questions. That it is meant for that.
Okay, okay,
That
sir.
is how we will know whether you have understood or you have not understood. If you can clarify then and there.
Okay, sir.
Swarup, whatever you have put up, it is for your esophagus and esophageal junction there. So is it adeno-CA, that
Both are
approach?
there. Both are there.
Adeno and squamous. Okay.
They should just go through pages 9 to 32. So what if they go through that, they'll get to know the actual management. The mainstay of management will be to decide when to put enteric tube, when to see whether person is resectable or not. Those kind of questions come. So they should know when a
Hmm.
person is considered unresectable. All those things will come. Sir.
Hmm. Sanya, anything?
Nothing, sir. He should have presented in much better format, I felt, because he usually does present very good.
Hmm.
This time, a lot of confusion was created. But otherwise, he was
Hmm.
good, sir.
No, that's what I think he had not understood that the management
Yes,
varies.
yes.
He was trying to present it in a
Generalize
generalized
it
way.
for everything. Yes, sir.
Yeah.
Yes.
Okay. Nikita?
Sir, as per the guidelines, it was little confusing, sir, at the beginning.
Hmm.
Can you hear me, sir?
Yeah, yeah. Go on.
Because
Hello.
yes, sir, it's very customized to
Yeah.
the different part and different type of surgery, type of
Hmm.
carcinoma. So it was confusing, but overall, it's almost considering the patient general condition as well as the type of the surgery, type of the carcinoma.
Just remember the
Hmm.
variables here: patient general condition, comorbidities,
Yes,
nutritional
sir.
status, type of carcinoma, the adeno versus squamous, location, and patient
Okay.
preferences also. Somebody may
Yes,
want
sir.
to avoid cells. So all these things are there, and when questions come in the exam, viva somewhere, be very defensive in what you answer. Don't commit to any particular
Yes,
treatment
sir.
modality and say this is the. Samir did that mistake. He was trying to say substance is what he said is right. That should not happen in a real exam. If somebody is asking the
Yes,
same question again and again, they should realize that there could be a fault in what they've understood.
And also,
Uh,
I think in exam they are very specific. They will give you the T staging, N staging, and they will mention adeno or squamous. And then they will ask you to drop a plan for management. I think that is like that only, no,
yes,
Nikita.
sir. Yes, sir. Yes, sir.
Yeah. So they will be very specific. Yeah. Sir.
Yeah, I think you from usual Sameer standards, this was maybe because it's a very difficult topic. I think even for us, it's because as Swaroop said, things are evolving so fast that making decisions based on what was available even a month ago is maybe difficult. So on that count, I think Sameer probably is not usual presentation, but it is a tough topic. So I think we should put in more effort to to make it more succinct and easily understandable.
Yes, sir. Niharika ma'am?
I think he presented okay in the sense like NCCN guidelines for esophageal carcinoma is a little bit tough to understand, and I think I have gone through NCCN for esophageal at least 4 or 5 times during exam and whenever we have patients, and it is little bit tricky to recollect. But yeah,
Yes,
I
sir.
must say I think he's done okay. So he's not done that bad a job
Yeah,
as well.
yeah, yeah, yeah.
Sure.
Yeah. Swaroop, final comments?
Fair enough. He just has to read again, he'll remember everything.
Yeah, yeah. So what we had expected, Sameer, was for you to not to be aware of each and every guideline. What we wanted you people to understand is that management will eventually vary on, as Saurabh said, patient's condition. More than that, even before that, it is the patient's where is the tumor, site of the tumor, type of tumor, and eventually it depends on the patient's general condition as well. So based on that, you need to understand the management of esophageal cancer. And I hope at least most of you have understood now after all this discussion how you have to approach it, and probably you have to go through the guidelines and the management what Swaroop has put up in detail, and you will understand it even better. And hopefully next class Samir will be better prepared for surgery. Samir, thank you.
Yes, sir. Yes. Yeah.
Yeah, thank you. If no other questions, we will end
I
the
think,
class.
yeah. I think the first thing is now, probably what you have to understand is MDT is level 1A evidence. Every cancer has to be gone through, has to go through the MDT before any decision is made. And second, this pathological complete response, clinical response is becoming more and more with the newer treatment, and organ preservation is becoming more and more relevant. So that is why the phase of surgery will keep changing. That is what you have to understand. Okay, good night.